Greetings and welcome everyone to another episode on Oral Pathology 360. And today's episode is about something that's very dear, I think, to everyone who is a dentist, and that's dental caries. I think it is the most fascinating disease of all, simply because it's capable of, destroying teeth premortem very easily, while teeth are among the, in fact, they are the most indestructible tissue that we have postmortem. It's really amazing the difference, and the difference I think is not so much the teeth, but the disease, and that is dental caries, a truly fascinating disease. And we are going to learn a little more about it today in the updated version of what's happening from Dr. Kia Sarkar, who is with us today. And let me bring her in. Right. Welcome, Dr. Kia. It's wonderful to have you here with us.
Yeah, hi Mandana.
Yes. So, and just to let you know, Dr. Kia is the Dean of Jamia Millia Islamia University. And yes, she is, of course, an oral pathologist otherwise. So, I think with this short introduction, let's go on and watch the lecture together. Then we will come back and have our regular live discussion. And for that, of course, you need to be logged into YouTube. In the meanwhile, do let us know where you are logging in from and leave your name and place, and it will be great to know. And we'll catch up with the questions and the discussions after this.
Good evening, everyone. It's a great pleasure to be with you all today, and I thank Dr. Mandana for the opportunity and indeed commend her tremendous efforts in sustaining and building this oral pathology platform. I come to you from the Faculty of Dentistry, Jamia Millia Islamia, New Delhi, and my topic for the day is about a lesion which dental surgeons encounter day in and day out. It's not glamorous, it's one of the oldest diseases known to mankind, but it still remains a mystery as far as our understanding of its etiopathogenesis is concerned. The topic for the day is changing perspectives in dental caries. As long back as 5000 BC, a worm was believed to produce a hole in teeth. This condition was termed as dental caries in 1634 from the Latin word caries, which means decay. The role of microorganisms in dental caries was first elucidated by van Leeuwenhoek in 1676 and then established by Miller in his seminal chemico-parasitic theory. Lactobacilli have been isolated from the mouths of people with caries, and then back then in 1924 Clark identified strep mutans in dental caries. The critical role of microorganisms in dental caries was further confirmed through experiments which showed that antibiotics can at least partially prevent caries and that dental caries could not be induced in notobiotic or germ-free rats. Definitions are the standard way of trying to understand the nature of any disease. Schaefer defined dental caries as an irreversible microbial disease of the calcified tissues of the teeth, characterized by demineralization of the inorganic portion and destruction of the organic substance of the tooth, which often leads to cavitation. The major takeaway message from this definition is that dental caries is a process of progressive demineralization, which obviously implies that it is an irreversible disease. Another important definition was given by Ernest Newbron. This rather complex definition states caries is not simply a continuous and unidirectional process of demineralization of the mineral phase, but appears to be cyclic, with periods of demineralization immediately following metabolism of a fermentable substrate by the plaque flora, interspersed with periods of remineralization. The major takeaways from this definition are that it is a cyclic process of demineralization and remineralization, which then implies that it is not an irreversible disease. This This was followed by a definition given by the National Institute of Health in 2001. This definition states that dental caries is an infectious, communicable disease resulting in the destruction of tooth structure by acid-forming bacteria found in dental plaque and intraoral biofilm in the presence of sugar. The infection results in the loss of tooth minerals that begins on the outer surface of the tooth and can then progress through dentine to the pulp, ultimately compromising the vitality of the tooth. The major points in this definition were that dental caries is an infectious, communicable disease and that it develops in the presence of sugar. We would all agree, I think, that the definitions, all these standard definitions, are not in agreement with each other, which shows that we don't understand the true nature of this very common disease. From the evidence available so far, the understanding of dental caries rests on two facts. One, that it is a transmissible infectious disease caused by strep mutans and hence can be prevented by vaccination. And two, that tooth resistance to dental caries can be increased with fluorides. Systemic fluorides would yield maximum advantage, but the increased resistance to dental caries has to be balanced against the possible increase in the incidence of systemic fluorosis. However, in 2019, the FDI and the IADR issued a statement that dental caries is a non-communicable disease. Like all NCDs, dental caries develops as a result of a combination of genetic, physiological, environmental, and behavioral factors. The global burden of disease study reveals that untreated dental caries was the most prevalent among 291 medical conditions that were evaluated as part of the study. Dental caries has a huge impact on the quality of life and huge financial implications for individuals, families, and society in general. This is indeed a serious concern as the prevalence of dental caries has hardly reduced even though it is basically a preventable disease. The concept of dental caries being a non-communicable disease requires big changes in the way that dental caries has to be managed at all levels. The whole perspective of how dental caries has to be managed has to change to effectively reduce the burden of disease in the society. We have to think about whether dental caries is actually an infection as it was previously believed. The main foundation of moving away from the infectious pathogenesis is that dental caries does not follow the three canonical Koch's postulates. Koch's postulates, which are the cornerstone of labeling a disease as an infectious disease, states that the microorganism must be found in abundance in all organisms suffering from the disease, but should not be found in healthy organisms. However, in dental caries, the putative pathogen, that is strep mutans, is detected in disease, but is also present under healthy conditions. According to Koch's postulates, the microorganism must be isolated from the diseased person and grown in pure culture. However, in dental caries, there is not a single specific bacterium, rather it is polymicrobial caused by commensal bacteria which acquire the potential of causing disease when there is dysbiosis. Such microorganisms are often referred to as pathobionts. According to Koch's postulates, the cultured microorganism should cause disease when it is introduced into the healthy organism. However, the mere presence of the putative organism strep mutans does not cause dental caries. According to Koch's postulates, the microorganism should be re-isolated from the diseased experimental host and identified in culture as being identical to the original specific causative agent. However, there is no specific causative agent identified in dental caries. The etiology of dental caries was explained earlier by the specific plaque hypothesis when it was believed that strep mutans causes dental caries. Hence, the management aimed at elimination of the causative bacteria with various antibacterial substances and also vaccines. Dental caries develops even in the absence of strep mutans, and so the one pathogen, one disease dogma has been replaced, the specific plaque hypothesis has been replaced by the non-specific plaque hypothesis, which attempted to explain the etiology of dental caries as the result of the net metabolic activity of the biofilm. So, is the dental biofilm enough to cause caries? The human body comprises eukaryotic and microbial cells in equal numbers. These microbes, which constitute the microbiome, live in harmony with human cells in the particular ecological niche that they occupy. It is only when this harmonious relationship breaks down due to some change in the local environment that disease can occur. Thus, just the presence of the biofilm does not cause caries. Early childhood caries is a very aggressive form of dental caries in which children affected by the disease are characterized by a very heavy load of strep mutans. Infants acquire strep mutans from the primary and secondary caregivers, and it is seen that the presence of strep mutans before the age of 3 years correlates with a higher strep mutans load as well as higher DMF index by the age of 19 years. Thus, preventing acquisition and colonization of strep mutans may play an important role in preventing dental caries. Due to its unique attributes of acidogenicity, aciduric nature, and its ability to produce EPS or extracellular polysaccharides, strep mutans can drive the production of a highly cariogenic biofilm when dysbiosis occurs due to the frequent exposure to dietary sugar. The oral biofilm in children with early childhood caries also contains Candida albicans in significant numbers. Candida has a symbiotic relationship with strep mutans. In the presence of sucrose, the extracellular polysaccharides produced by strep mutans binds with great avidity to the surface of Candida albicans. This increases the amount of EPS in the biofilm and also enhances its virulence or karyogenicity. In recent times, various omics-based platforms have been used to study the etiology and pathogenesis of dental caries. These new omics-based studies show that strep mutans, in fact, accounts for only 0.1% of bacteria in the oral biofilm and only 0.7 to 1.6% of bacteria in carious lesions. On an average, 8 different bacteria were present at more than 1% load in enamel and dentine lesions, and also the combination of these bacteria varied from case to case. The bacterial diversity was found to be lowest in enamel caries with about 177 species per sample and highest for open dentine cavities, which showed almost 251 species per sample. In hidden dentine cavities also, more than 201 different species were detected. The evidence from these studies suggests that dental caries may indeed be produced by different sets of microorganisms. In fact, metagenomic studies of the human microbiome does indicate that different groups of microorganisms can perform similar functions and have similar effects or outcomes. The most significant thing then appears to be what is causing the dysbiosis. The etiology of dental caries, we agree, is not completely specific in terms of the microorganisms that cause it. Rather, it is a shift in the ecology of the biofilm due to a change in the local microenvironment that results in dental caries. This concept has been elucidated in the ecological plaque hypothesis to explain the etiology of dental caries. According to this theory, dental caries is not caused by a specific type of microorganism acting alone, but is the result of a shift in the microbiota of the dental biofilm towards more cariogenic species due to a change in the local microenvironment. The main driver for this dysbiosis is the frequent consumption of sugar. Fermentation of these sugars produces a low pH state in which acidogenic and acidiuric bacteria thrive, leading to increased karyogenicity. Besides sugar, reduced salivary flow and ineffective plaque removal also drives the dysbiosis. Thus, interference with the drivers of dysbiosis is required in order to prevent dental caries. As the virulence of the biofilm is influenced by overexposure to sugars, complex interspecies and in fact cross-kingdom interactions, current prevailing methods of caries assessment based on strep mutans levels are neither accurate nor effective. All non-communicable diseases, and particularly diabetes and obesity and dental caries, have similar health risk behavior patterns. These patterns include high sugar consumption, poor dietary habits, and deficient biofilm control. The WHO report on oral health emphasizes the need to address the common risk factors of oral diseases and other NCDs through an integrated approach that focuses on the key risk factors. Besides sharing risk factors with other non-communicable diseases, dental caries incidence is also related to systemic health. Dental caries, which is the main reason of tooth loss. Although causality has yet to be established, tooth loss shows strong association with myocardial infarction, ischemic stroke, and death outcomes. In fact, having more than 5 missing teeth substantially increase the risk of poor outcome in cardiovascular disease. Severe dental caries can induce atherosclerosis and exacerbate cardiometabolic risk factors. A strong association has also been reported between the incidence of dental caries and cognitive disorders like dementia. The management of dental caries, therefore, has to, in fact, go beyond the tooth if the disease burden is to be reduced. The restorative approach to treat dental caries has not reduced the disease burden. It only serves to limit the damage already present. Preventive strategies, which have largely aimed at reducing net mineral loss with the use of fluorides, have largely been ineffective in reducing the burden of disease. An interesting data point is the restoration cycle or the spiral of death of a tooth. It has been seen in many studies that over a period of time, a tooth affected by a small carious lesion is ultimately lost after having gone through a cycle of various types of restorative treatment over time. A new way of looking at dental caries is that it is not a transmissible disease in terms of transmission of the causative bacteria from one person to another. However, due to social and cultural factors, unhealthy habits with respect to sugar consumption, biofilm control, and periodic checkups is often, in fact, transmitted from one person to another within the same community. With the perspective that frequent sugar consumption drives dysbiosis leading to dental caries, WHO recommends to reduce simple sugar consumption to less than 5% of the daily caloric requirement. For children under the age of 2 years, it is recommended to avoid adding sugars to food or drink. A protein and fiber-rich diet should be promoted. However, to be effective, individual measures do need to be combined with public policy and oral health care programs at the community level. So, how is dental caries to be managed at the community level? Just like we cannot ignore tobacco consumption and focus our efforts on treating oral cancer, which is the effect of tobacco consumption, so too we cannot ignore sugar consumption and focus all efforts on treating the effects of sugar consumption like dental caries, obesity, and diabetes. Hence, the catchphrase, sugar is the new tobacco. Although dentists are not exempt from the from raising awareness and implementing dietary assessment and counseling as part of their daily work, sugar consumption is in fact associated with addictive patterns and emotions with a strong neurobiological support. The dental surgeon in isolation cannot achieve this goal effectively. Hence, an interdisciplinary approach with collaboration between dentists, physicians, psychologists, nutritionists is required. As academics involved in curriculum planning, it's also important to ensure that dental students achieve better competency in working with an entire health team as part of a multidisciplinary approach rather than prioritizing only the restorative aspects. Studies on the management of dental caries in pregnant women and children using an interdisciplinary approach has shown good results. The involvement of an entire health team also ensures better access to oral health care among marginalized people who often don't go for conventional dental treatment due to financial implications. With an integrated approach to dental caries as a non communicable disease, it is conceivable that oral health and oral examination will get included in general health checkups where it is often neglected. Also, oral health will get its rightful place in the therapeutic management of systemic diseases. Thus, when we accept dental caries as a non communicable disease, we accept that it must be managed at individual level and at community level. At the individual level, the focus must be on healthy lifestyle, sugar restriction, biofilm control. Avoid exclusive restorative management of caries in exclusion of the other factors. At the community level, public policy has to be framed for early intervention during pregnancy, increasing oral health literacy in school children, and processed food labeling to reduce sugar consumption. Dental surgeons must be included in all government level NCD programs to effectively drive the importance of reducing dental caries in society. At the end of this, I hope I have been able to convey the need to look at dental caries through a different lens. That is the lens of a non communicable disease. The change in perspective should reflect in what we, who are academics, emphasize to our students. The questions we ask in examination question papers and vivas. It is necessary, I think, for us to believe in the evidence that clearly points to the fact that dental caries is a non communicable disease. With the change in perspective, one can hope for a reduction in the prevalence of dental caries. Thank you.
And we are here to discuss them. Until everyone else puts in their questions, let me 1 second. Okay, good evening, Dr. Hazare. Yes, sir also has joined us, and he has a comment that relates to what you were saying about sugar being the new tobacco. So he calls it white tobacco.
Yeah.
Right. Thank you, sir. So, um, I must say, all the evidence is there, but I'm still not completely convinced that it is entirely right to call it a non communicable disease. What do you feel? I mean, I know the evidence was there, and I know that's what the presentation says, and that's what the WHO says. But as your own opinion, what do you feel?
Yeah, like we have been reading our textbooks right from the time that we were students, and everything points towards it being caused by these microorganisms. And then you find that, okay, your vaccines don't work, there is no antibacterial which helps to control it. You also find that no matter what, like, the data shows you that the prevalence of dental caries is not decreasing. I think this evidence shows that it is not about a particular cause. So we have to accept that there is something in the behavioral pattern, I think we can call it, and in that way, it is being grouped under non-communicable disease. Definitely, whether we understand non-communicable diseases now, as like earlier, diabetes also was supposed to be caused by, one did not group it under a lifestyle disorder, but now it's a lifestyle disorder. So similarly, I think from that perspective, yes, I do feel that it is factors beyond it being a microbial disease, which we have traditionally been learning, and that's why I do feel that when we are teaching the students, there's a lot of emphasis on the learning the theories, learning the etiology. I don't think we are emphasizing enough, and maybe people don't consider it important because ultimately they go, it is only about the restorative treatment. So I think one does need to somewhere understand that these other factors, which have been observed earlier, like the role of sugars, has been observed right from Miller's time. But it is now that you have evidence about it being so important in the causation of dental caries. So even in terms of management, this needs to go down, that it is not just a physical process of doing a restoration and how well you do it and maybe how good your materials are in terms of bonding. There are factors beyond that, so you have to work on controlling those factors also. So whatever be the definition of non-communicable diseases, the role of these other factors has to be realized, and I think it should become a part of management, which I do feel it's not. Like, it's not part. When a person goes to a dental surgeon, yeah, it's like, yeah, meetha kam khana chahiye, bachcho ko meetha nahi do, but it's not clearly understood that it is causing the disease as such.
That is very, very true, of course, and very well said. I think we put in a lot of time studying those many, many theories,
Hmm.
more out of
Including
a
ancient
historical
theories, right?
aspect of
Yeah.
trying to, build up, I don't know, a timeline and the
Hmm.
progression maybe. But truly, I don't think any of the students really learn any of it, and it's just
Yeah.
time that is that could be better spent. You very well said. Although they're all very fascinating theories, but yeah, I don't think
Yeah.
for undergraduates those are the best things to be teaching them.
Correct,
And
but it's only
totally
if it comes in the management, the importance of this, only when it is applied and translated into the clinical management, then only one understands the significance of those
the
things.
significance, yes. My way of saying, or my thinking, why I was saying that I'm not fully convinced, is not that in a lot of ways, especially today when we think about non-communicable diseases as being very lifestyle related and things like that, chronic and lifestyle related. Definitely it has always been lifestyle, because essentially without the sugar, it's like both the things, actually speaking, it's interesting, but those Venn diagrams we learned are actually
Hmm.
still holding true. And
Correct.
without all those factors together and overlapping, we don't have caries. My
Absolutely.
way of thinking is equally important is not to forget, or you know uh, go to the other extreme and now stop thinking of the infection involved, of the bacteria involved, because they are also equally important. It's not an entirely sugar related. If you don't
No,
have
no.
the related bacteria, you still won't have the disease.
Absolutely, absolutely. But
Yeah,
it's like in just the present, the bacteria are anyway present, right? They are
yeah,
present anyways in the oral cavity. It's only if there is a shift in the microenvironment, then only it will drive towards caries. That's the
Carries, yes.
that's what we understand. Yeah.
Yeah, that's what just my worry is that now we will go to the other extreme, and just totally forget, begin to think that bacteria don't really have a role. And that's my only worry. We tend to sometimes go to extremes with things. But yes, and of course, I have to accept I'm biased. I'm particularly fond of Streptococcus mutans because I think they are among the most fascinating bacteria ever. I can't think of any
Yeah, like
bacterium that has the
mutant
abilities that it
organisms.
does have. I
Yeah.
mean, it's an amazing organism in terms of its ability to survive. Uh, it's just it's been one of those things. So yes, I begin to think that I have to say that I'm rather biased about that. Okay, let's see. We have some other comments. Let's see what we have. Dr. Guru Rajarao, yeah. Now dental caries has become reversible. It is true. It is though progressive.
Yes, I think that has been recognized from the concept of demineralization, remineralization. So, yes, the idea that it is reversible, I think, is now accepted, even from the point of view of materials being developed and restorative management.
Yes, very. And I think even what you were saying about that, the life cycle of death of a tooth, finally, it is about caries. I mean, caries is involved,
Yes,
and each time it progresses. Yes,
yes. I guess a lot of the times it's put down to poor treatment and things like that. But
exactly.
there are intrinsic factors which are
Factors.
also driving that cycle.
Yes, very much so. That was a very good point you added to the lecture. Something that's often not really included. Okay, we have another comment from Guru Rajulao sir. Beyond mouth, dental caries is also close to heart disease as well. Yes,
Yes, I think that is the point of it being included in the list of NCDs. That
see.
there are these studies, of course, which associate high prevalence of dental caries with coronary disease and atherosclerosis, and now even cognitive disorders and everything. But what I read, I could not really find any causality, so to say. So association is has been reported, of course, for periodontal diseases, also for dental caries, also, and obviously a lot of work has happened in that. There are all the inflammatory mediators, so some amount of if there is one disease, the other disease would also tend to happen because of the same inflammatory mediators. And that's why dental caries is relatively so easy to detect, and if it is possible to even reduce, it's important to try and reduce the prevalence. That's what I'm saying. It's not something that one just assumes that okay, people will get cavities and then you just go and get a restorative like a physical treatment done. The biological basis, I think, is somewhere we don't give enough importance to it.
Very true. Sorry. Okay. Dr. Nandini says thank you. That was really a very nice lecture. Let's see what Dr. Nasser. Economics, poverty, and sugar dependence. To get calories must be looked at by governments at school levels. Yes, that is an entirely interesting and another aspect that we
Yes,
don't think
yes.
about.
Hmm. And Dr. Nasser, I think this happens actually at both levels. In the so-called developing nations, it's like they get their calories from carbs and sugars. That's also true, but I think it's also seen that in the developed nations, there is a tendency towards eating a lot of refined food and a lot of simple sugars. So I think it's yes, economics, but also lack of awareness, which although I must say that nowadays there is a lot of increasing awareness about avoiding sugar. But in general, the coke consumption and all this is highest in the developed world.
That is true. But
So
I also
the whole
would,
thing of
when we
junk
would
food or
normally
whatever.
think
Yeah.
about, about sugar consumption, we think in terms of the first thing that comes to our mind is people who have a choice and, just
Hmm.
basically are not either not aware enough, informed enough, or not bothered enough to avoid it, because sugar is, as we know, of course, is the a food that makes you feel nice. It's a comfort food. So
Yes.
so that's what we normally think about. We rarely think that it may not be so much as just feeling like having it, but maybe very rightly, as Dr. Nasser said, is that it might be actually a necessity for some people, which
Correct.
we
It's
normally
often the
don't think about.
yeah.
It's very true. Yes, that's true, Dr. Nasser. The UN is trying, but yeah, that's not enough. Then again, I think we can normally say that whatever the UN tries is generally not enough.
Generally not enough. Yeah.
I mean, on multiple levels, it's just
Mm. Mm.
it's an effort. Yeah, and yes, it should be at countries level too.
And I
Yeah, I
think
think a
what
lot
great
of countries
increasing
are having
awareness
sugar
is
tax.
required.
Sorry, please
Hmm.
repeat that.
Yeah, no, I said that there is a need for increasing awareness, I guess. Like in
Yes,
general, there is an awareness about avoiding fats. Traditionally in India, the fried foods were very much part of your normal, regular food. But now almost everyone avoids it because there's a lot of awareness of cholesterol and what is your triglyceride levels and everything. But the same kind of correlation of sugar with uh, maybe diabetes, maybe obesity, yes, but with dental caries, not so much, I think.
not so much. Right, that is true. I feel that that is mostly because there's a definite and identifiable gap between dentistry and medicine,
Correct.
and
That is why
unless we
also,
can,
hmm. Yeah,
yeah,
go
unless
ahead,
we can
Mandana,
get the
sorry. Hmm.
two somehow closer together, we are doing the same things. I mean, this message about sugar being bad for teeth can very easily be carried along with the messaging that is already happening.
I think that's why they are talking about it being it should be a team thing. So there should be an interdisciplinary, you know, work where you're not talking just about weight loss when you say about reducing your sugars, but you're talking about all this and the fact that dental caries also is not an isolated occurrence. If dental caries is happening, probably your risk of diabetes is higher, your risk of obesity is higher. So this whole correlation is what needs to be emphasized, and I think that's why inclusion under the non-communicable diseases helps to drive that story.
Yes, that is definitely true. And I think in the it also helps getting this included in the WHO's sustainable development goals, which are health for all, and which
Health for all,
considers
yeah.
health as a collective thing
Hmm.
and includes oral health for the first time, although I think it is
Yes.
from 2015. So but we have not really worked on it as much to get it as much of a focus as the
Hmm.
other parts.
Hmm.
But it's definitely a good move. And let's hope by 2030, I think, is supposed to be the time when this
2030
phase,
sustainable
yeah,
goals, yeah.
when this phase is supposed to end. So let's hope by then we have a better setup, because as it is right now, I think dental caries, periodontal disease, and I mean, the two of them together are the most common diseases in the world,
Yeah.
affecting more than half of the world's population. So, yes, let's hope we can make a difference and reduce it with better information. Dr. Guru Rao. Thank you, Dr. Kia. Very nice lecture. Truly, very nice
Thank you,
lecture.
sir. Thank you, sir.
Yes. So, anything else you want to add? I think we have reached the end of our comments and questions.
No, thank you so much, Dr. Mandana. I know I troubled you a lot with this, but thank you. It was a nice experience. I enjoyed
No, no,
doing this.
that's all right. I understand the amount of work you must be having and the number of things, administrative and otherwise, that you have on your plate. So it
Well,
was
it
very
was it
kind
was
of
nice
you, in
doing this. It was
fact.
nice to go through the literature, and you only do it under pressure nowadays. But it was nice. Yeah. So thank you for the opportunity.
Yes, no, thank you. It was a wonderful presentation. Thank you. And it's my favorite topic, so I also thoroughly enjoyed listening to it. Um, Thank you so much. You did all the work that otherwise I don't get the time to sit and review the topics. This was great to have it ready
Thank
made
you.
and just hear it in 20 minutes.
Hmm.
Very, very good. Yes.
Thank you. Thank you.
Yes. Okay. I think, yes, Dr. Nasser also is saying great presentation. And, oh, Dr. Vangi is here with us after a long time. Hi. Okay. He says we missed most of the lecture, but is dental
Is dental
caries all the
caries
time outside, inside, or inside to outside?
okay? So I don't know. I don't believe it can be from inside to outside. I would love to hear Dr. Banki's thing on that, but I don't think it can be from inside to outside. No.
Yeah, I agree with you. Totally. Somehow there was that old one thing about how it started inside, but I never
Mm,
found that very
mm,
convincing. I don't know what
yeah. Mm,
Srinivas thinks. He also does a lot of work on dental caries. It would be
yeah.
interesting
Yeah.
to hear. So
Yes.
please
Yes.
type in what is your opinion or where you stand on the conversation on that. Okay. In the meanwhile, Dr. Punit also is here. Hi, Dr. Punit. And he says, congratulations, Kia, for the excellent presentation.
Nice to see you, Dr. Puneet.
Yes. Okay. And right, I think we have everything covered. No more questions. If there are any questions, still you can put it while I share Dr. Kia's certificate. Yes, here's your certificate.
Thank
And
you.
thank
Thank you.
you. Thank you so much for all the effort, for being here and sharing all your experience and your thoughts. Excellent. Thank you.
Thank you so much, Mandana. And thank you, everybody who made time to be here on this. Thank you.
You are most welcome. Okay, Srinivas has put something. I spoke about it during my lecture in DCI. Okay,
Yeah, that
Srinivas.
was a very nice lecture. I remember that very comprehensive it was. Yeah.
Yes, true. Okay. At this moment, I cannot remember exactly what you said, Srinivas, even though I attended
Hmm.
it.
Hmm.
Okay. We'll have to catch you. Probably we'll catch you in the conference and ask you. Okay. Dr. Nandini is asking role of acidosis.
Uh,
Acidosis. Okay, she has
do you
retracted
mean a
that.
low pH in the biofilm? Is that what you mean by acidosis, Dr. Nandini?
I think she has actually retracted that. Something went there. Okay, never
Okay.
mind.
Okay.
Then Dr. SJ says thank you. And of course, yes, sure, Srinivas, we shall meet and discuss dental caries at length. Okay, right. So, with this, let's tell you all about next week's lecture. In the meanwhile, so next week we have burning mouth syndrome, another very interesting topic, and this is being presented by someone from oral medicine. So we have diagnosis to management. As usual, of course, it's a free live event and it is right here on our channel. Same time, same place, and we hope to see you all then. Thank you, Dr. Kia, and thank you, everybody. See you next week.
Thank you. Thank you.
Welcome. Bye bye. Have fun. Be safe. And we'll catch up later.